Welcome to another episode from the Veterinary Research Channel. The delicate balance of acids and bases within the body is absolutely vital for maintaining good health, and our furry feline companions are no exception. The kidneys play a crucial role in this regulation, primarily by reabsorbing bicarbonate, a key buffer, and by generating new bicarbonate through a process called net acid excretion. This daily acid excretion relies on two main components: titratable acidity and, importantly, ammonium excretion. Ammonium excretion is especially significant because it can dramatically increase as a compensatory mechanism when the body faces metabolic acidosis, a condition where there's an excess of acid. When these mechanisms falter, particularly in conditions like progressive chronic kidney disease, serious health problems can arise. Electrolyte imbalances, bone disorders, muscle weakness, and even cardiac arrhythmias can occur due to disruptions in acid-base homeostasis. In humans suffering from chronic kidney disease, a substantial portion, as much as 40%, can develop metabolic acidosis. It appears that a reduced capacity for ammonia excretion is a major driving force behind this. In human medicine, the gold standard for assessing ammonia excretion is the direct measurement of urinary ammonia, often reported as the urine ammonia-to-creatinine ratio, or as daily excretion if a 24-hour urine sample is available. However, collecting urine over a full 24-hour period is often impractical in our veterinary patients. Interestingly, studies in humans with chronic kidney disease have revealed that impaired ammonia excretion is linked to poorer clinical outcomes, including a faster progression of the kidney disease and increased mortality. Metabolic acidosis is also a well-recognized complication in cats with chronic kidney disease. Prior research into the acid-base status of these feline patients has suggested a tendency for decreased ammonium excretion as kidney disease advances, indicating a reduced ability for cats with chronic kidney disease to compensate for acidosis. The urine ammonia-to-creatinine ratio can provide an estimate of the amount of ammonia eliminated in the urine over a 24-hour period, and a normal range for this ratio has been established for healthy cats. Despite the potential prognostic value of measuring urine ammonium, it's not a test that is readily available in most veterinary practice settings. Because of this limitation, researchers have explored more easily measured values or calculations, such as the urine anion gap, to see if they could serve as appropriate surrogate markers for urine ammonium. The urine anion gap is a calculated value that aims to represent the difference between the unmeasured anions and unmeasured cations in the urine. One of the simplest and most commonly used formulas for calculating the urine anion gap is the sum of sodium and potassium concentrations minus the chloride concentration. These three electrolytes can all be measured using standard laboratory assays that are widely accessible. Some of the most common unmeasured anions present in urine include sulfate, phosphate, and various organic anions like citrate. On the other hand, some of the most prevalent unmeasured cations in urine are ammonium, calcium, and magnesium. In human medicine, the simple urine anion gap calculation described earlier has unfortunately proven to be a poor substitute for directly measuring urinary ammonium concentration, especially in patients with chronic kidney disease. It's important to remember that the concentrations of both measured and unmeasured anions and cations in feline urine may differ significantly from those found in humans, potentially due to variations in diet, urine concentration, and the presence of different metabolic byproducts. Therefore, the relationship between the urine anion gap and urine ammonia in cats might also be different from what is observed in people. The primary goal of a recent study was to thoroughly evaluate the correlation, if any, between urine ammonium levels and the urine anion gap in both healthy cats and cats diagnosed with chronic kidney disease. The researchers also aimed to determine if the urine anion gap could be a reliable surrogate marker for the urine ammonia-to-creatinine ratio in cats. A secondary objective was to investigate whether there was a significant difference in the urine anion gap values between healthy cats and those suffering from chronic kidney disease. To conduct this research, the investigators utilized two sets of stored urine samples. The first group consisted of samples from 59 healthy client-owned cats that were presented to the University of Florida Primary Care Service for routine wellness examinations. These cats were categorized as healthy based on their medical history, physical examination findings, routine blood work, and urinalysis, all of which showed no signs of clinically relevant illness. Cats were excluded from the healthy group if they had elevated kidney waste products in their blood, azotemia, or any other disease likely to affect kidney function, such as hyperthyroidism, even if they weren't showing obvious clinical signs. The second group of urine samples came from 17 cats diagnosed with stable chronic kidney disease at International Renal Interest Society stages 2 through 4, who were patients at the University of Florida Nephrology/Urology Clinic. To be included in the chronic kidney disease group, cats had to have a consistently elevated serum creatinine concentration, greater than 1.8 milligrams per deciliter, or an elevated serum symmetric dimethylarginine concentration, greater than 18 micrograms per deciliter. Along with the documented inability to appropriately concentrate their urine-specific gravity less than 1.045, on at least 2 separate occasions when they were considered stable, less than 25% change between measurements, and adequately hydrated based on physical examination and serial body weight measurements. Cats from both the healthy and chronic kidney disease groups were excluded if their urine samples showed visible blood, a high number of white blood cells, 5 or more per high power field, or evidence of bacterial infection. They were also excluded if they had received certain medications known to affect urine composition, including glucocorticoids, diuretics, urinary acidifiers, alkalinizing agents, or angiotensin-converting enzyme inhibitors, or if there was not enough urine sample available, less than 100 microliters. Importantly, all cats, both healthy and those with chronic kidney disease, were fasted overnight before their urine samples were collected. The urine samples were collected using a sterile procedure called cystocentesis, and multiple small portions of each sample were immediately frozen and stored at a very low temperature, -80 degrees Celsius, within 6 hours of collection. For the measurements of urine ammonia and creatinine, a single portion of each thawed sample was centrifuged. For the measurements of sodium, potassium, and chloride, separate portions of each sample were thawed at room temperature and briefly mixed. A minimum of 100 microliters of urine from each sample was then sent to the University of Florida Small Animal Clinical Pathology Laboratory for analysis. Along with the urine analysis, demographic data for each cat, such as age, breed, sex, and weight, were recorded. Additionally, the serum bicarbonate concentration, a measure of the body's buffering capacity, was recorded, and cats were classified as having metabolic acidosis if this concentration was 16 milliequivalents per liter or less. For the cats with chronic kidney disease, their specific stage and substage according to the International Renal Interest Society guidelines, based on serum creatinine concentrations, systolic blood pressure, and urine protein-to-creatinine ratio, were also recorded, as well as information on whether they were being fed a special renal diet. Urine ammonia and creatinine concentrations were measured using commercially available enzymatic assays. The reliability of these assays, in terms of their consistency within a single test run, and between different test runs, had been previously established. The concentrations of sodium, potassium, and chloride in the urine were measured using an indirect ion selective electrode with a commercially available chemistry analyzer. Finally, the urine anion gap was calculated for each sample using the simple formula: sodium concentration plus potassium concentration minus chloride concentration. The researchers then used statistical methods to analyze the data, looking for correlations between the urine anion gap and the urine ammonia-to-creatinine ratio in both healthy cats and cats with chronic kidney disease, and to determine if there was a significant difference in the urine anion gap values between the two groups. A statistical significance level of p less than 0.05 was used to determine if the observed differences or correlations were likely due to chance. The results of this study included urine samples from 59 healthy cats and 17 cats with chronic kidney disease. None of the initially considered cats had to be excluded based on the criteria set by the researchers. The healthy cat group consisted of 32 male neutered, 26 female spayed, and 1 female intact cat, with an average age of 7.8 years and an average body weight of 5 kilograms. The majority were mixed breed cats, but several purebreds were also included. The group of cats with chronic kidney disease comprised 11 male neutered and 6 female spayed cats, with an average age of 12 years and an average body weight of 4.4 kilograms. Most of these cats were also mixed breeds, with a few purebreds represented. 12 of the cats with chronic kidney disease were classified as International Renal Interest Society Stage 2, 4 were Stage 3, and 1 was Stage 4. 11 of these 17 cats, representing 65%, were being fed a renal diet. When comparing the demographic and clinicopathological variables between the healthy cats and the cats with chronic kidney disease, the study found that the healthy cats were significantly younger and heavier. However, there was no significant difference in the proportion of male and female cats between the two groups. Interestingly, the median concentrations of sodium, potassium, and chloride in the urine were all significantly lower in the cats with chronic kidney disease compared to the healthy cats. The median urine anion gap for the cats with chronic kidney disease was 40, with a range from 20 to 156. This was significantly lower than the median urine anion gap of 120, which ranged from -23 to 468, observed in the healthy cats. Further analysis revealed that the urine anion gap had a weak inverse correlation with the urine ammonia-to-creatinine ratio in the healthy cats. This means that in healthy cats, there was a slight tendency for the urine anion gap to be lower when the urine ammonia-to-creatinine ratio was higher, and vice versa. However, no evidence of such a correlation was found in the cats with chronic kidney disease, nor in the entire combined population of healthy and sick cats. Additionally, the researchers found no significant difference in the urine anion gap between the cats with chronic kidney disease that were being fed a renal diet compared to those eating a non-renal diet. The researchers concluded that when the urine anion gap is calculated using only sodium, potassium, and chloride, it does not appear to be a useful substitute for measuring urine ammonia excretion in either healthy cats or cats with chronic kidney disease. While some earlier studies in human medicine had suggested a good correlation between this simple urine anion gap calculation and urine ammonia levels, more recent studies have reported findings similar to those in this feline study, indicating a poor correlation. Some of these human studies found that including additional anions, such as sulfates and phosphates, in the calculation could improve the correlation with urine ammonia. However, even with these additions, the urine anion gap did not seem to predict clinical risks as effectively as direct measurement of urine ammonia concentrations. Furthermore, while including sulfates and phosphates might improve the statistical correlation, it also requires measuring these substances, which, like measuring ammonia itself, is not routinely available in veterinary practice. The study authors also highlighted that the urine anion gap can be influenced by any differences between the absorption of electrolytes in the gastrointestinal tract and their excretion in the urine. Therefore, certain conditions, such as selective loss of electrolytes through vomiting or diarrhea, could independently affect the urine anion gap, without necessarily impacting the urine ammonia-to-creatinine ratio. The researchers reiterated that the concentrations of measured and unmeasured ions in feline urine are likely quite different from those in human urine, potentially due to variations in diet, urine concentration, and the presence of different metabolic byproducts. In human studies, it has been shown that bicarbonate concentrations in urine are generally negligible when the urine pH is below 6.6, suggesting that bicarbonate can be omitted from the urine anion gap formula in such cases. However, it remains unclear whether bicarbonate contributes more significantly to the urine anion gap in cats, especially when their urine pH is higher than 6.6. A notable finding of this study was the significant difference in the urine anion gap between healthy cats and those with chronic kidney disease. Interestingly, this difference was not in the direction that would be expected if it were primarily due to decreased ammonia excretion in the cats with chronic kidney disease. With less ammonium being excreted in kidney disease, one would expect a smaller contribution to the unmeasured cations in the urine, which would theoretically lead to a higher urine anion gap. However, the study found that the healthy cats had significantly higher median urine anion gap values compared to the cats with chronic kidney disease. The researchers noted that this finding aligns with more recent studies in human medicine. While earlier reports in healthy humans showed a lower median urine anion gap, more recent values are significantly higher, and the urine anion gap in patients with chronic kidney disease has also been reported to be higher in recent studies compared to older data. This shift has been suggested to be a real change, possibly related to dietary differences over time. The finding of a higher urine anion gap in healthy patients suggests a larger contribution of unmeasured anions in these individuals. Conversely, in patients with chronic kidney disease, the contribution of these previously unmeasured anions might be substantially decreased, or there could be a significant increase in the presence of other unmeasured cations. The primary recognized unmeasured anions that contribute to the urine anion gap are sulfate, phosphate, and organic anions. Studies in humans have shown that phosphate excretion tends to decrease as kidney function declines, which could contribute to the lower urine anion gap observed in patients with chronic kidney disease. This same effect might also apply to cats with chronic kidney disease. Furthermore, humans who consume diets rich in animal protein tend to have higher urinary excretion of phosphate and sulfate compared to those on vegetarian diets. Since cats with chronic kidney disease are often placed on protein-restricted diets, including the 11 out of 17 cats in this study who were on a renal diet, they might be excreting less urinary sulfate and phosphate, which are unmeasured anions, potentially contributing to the overall lower urine anion gap in this group. Although the study did not find a statistically significant difference in the urine anion gap between the cats with chronic kidney disease fed a renal diet and those fed a non-renal diet, the relatively small number of patients in each subgroup might have limited the ability to detect such a difference. The study also found that urine sodium, potassium, and chloride concentrations were all significantly lower in the cats with chronic kidney disease compared to the healthy cats. The researchers suggested that much of this difference could be attributed to the kidney's reduced ability to concentrate urine in chronic kidney disease, leading to a dilution of urine electrolyte concentrations and a proportionally decreased urine anion gap. However, they noted that simple dilution of electrolyte concentrations is unlikely to be the primary factor causing the lower urine anion gap in the sick cats. This conclusion was supported by a subsequent analysis that found only a weak correlation between the urine anion gap and urine-specific gravity. Additionally, some healthy cats with highly concentrated urine had urine anion gap values lower than those of cats with poorly concentrated urine. The researchers acknowledged several limitations to their study. A major limitation was the relatively small number of cats with chronic kidney disease included in the study. This small sample size limited their ability to effectively evaluate potential differences in the urine anion gap, or urine ammonia-to-creatinine ratio across different stages of chronic kidney disease, or within subgroups based on factors like diet or the presence of metabolic acidosis. Studies in humans have shown that conditions like renal tubular acidosis and respiratory alkalosis can lead to decreased urinary ammonia excretion that strongly correlates with an increased urine anion gap. Conversely, in humans with hyperchloremic metabolic acidosis caused by diarrhea, and in both humans and dogs with hyperchloremic metabolic acidosis induced by oral ammonium chloride administration, increased urinary ammonium excretion was strongly correlated with a decreased urine anion gap. The study authors speculated that a subset of their cats with metabolic acidosis might have shown a stronger correlation between the urine anion gap and the urine ammonia-to-creatinine ratio than what was observed in the overall chronic kidney disease group. However, they also pointed out that the ability of cats to effectively respond to experimentally induced metabolic acidosis with ammonium chloride has been questioned. Furthermore, in the human studies where ammonium chloride was given orally, the lower urine anion gap observed might have been partially related to the elimination of the extra chloride that was administered. Another limitation of the study was the lack of direct measurements of urine pH and urine bicarbonate concentrations. The researchers used the simplest urine anion gap equation commonly used in people, which often assumes that urine bicarbonate can be omitted, particularly at lower urine pH. However, they noted that this assumption might not be valid for cats, especially those with more alkaline urine. In conclusion, this study found that the urine anion gap, calculated as the sum of sodium and potassium minus chloride, does not appear to be a reliable indicator of urine ammonia excretion in either healthy cats or cats with chronic kidney disease. While modifications to the urine anion gap formula might potentially improve this correlation, they would likely make the calculation more complex and diminish any practical advantage of using the urine anion gap over directly measuring ammonia levels. The study did identify a significant difference in the urine anion gap between healthy cats and cats with chronic kidney disease. However, further research specifically designed to investigate this finding would be necessary to understand the underlying reasons and determine its clinical significance. Thank you for listening to the Veterinary Research Channel. A link for the reference paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.